right, let's begin. Let me know if I need to speak up or if you can't hear me. As Dr. Marr indicated, I'm going to talk about the psychological costs of illness and pain. So although this relates to Chiari Syringomyelia, a lot of the work I do with chronic pain patients, it doesn't really matter what the disorder is. So the takeaway for everybody that's dealing with chronic pain and illness is pretty much the same. There are three factors I want you to be aware of as we talk about what affects how we deal emotionally with pain and illness: catastrophizing, anxiety, and the fear of pain, avoidant behaviors, and also the concept of helplessness. So I'm going to break these out for you one at a time. And we can get into questions, obviously, when we get to the panel with these, but hopefully these will be fairly clear as I go through them. So pain catastrophizing is a psychological concept in which individuals tend to focus on their pain and they negatively evaluate their ability to deal with it. And catastrophizing can sound like this in somebody's mind: this pain is killing me. I can't stand it. I'm never going to get over this. My life is over. This is the worst it could possibly be. So what we're listening for is self-talk, the cognitions that go along with the evaluation that happens when we have pain or illness. And what's really interesting is that patients who have a tendency to catastrophize can influence the severity of their subjective pain complaints as high as 31%. So what that means is when you go to a clinician, when you go to a healthcare provider, a large percentage of the pain that you may be expressing is not physical, but actually emotional because of the way you're thinking about the pain. You're catastrophizing. So, what are the things that come up when we deal with catastrophizing? Patients who tend to catastrophize about their illness or their pain are much more disabled. They're less capable. They tend to use the healthcare system to a much greater degree. Their hospitalizations are a lot longer because they're convinced that they're much more ill perhaps than they really are. They tend to use more pain medications. There are increased motor pain behaviors. We look at such things as subjective pain behaviors: grimacing, guarding, complaining, whining, heavy breathing. There's all sorts of behavioral components that get manifested in people who tend to have exaggerated subjective pain complaints because of the way they think about their pain. Not unusual is they also take a much longer time post-operatively to reach goals for rehabilitation. They're more depressed. They're more anxious. They tend to rate or oftentimes have increased general medical problems. Their energy levels are lower. And going along with decreased behaviors, they have decreased limitations in terms of what they believe they can accomplish. They tend to be more socially isolated and withdrawn. And the caregivers, whom I'm going to talk about in the second half of this, tend to report higher levels of strain. Okay? This is all the psychological and physiological and physical responses to catastrophizing. Now we have pain-related anxiety and fear, and what I'd like you to pay attention to is as we go through this, you're going to see a lot of overlap with these three components between catastrophizing, fear and anxiety, as well as the concept of helplessness. And obviously, when we get into a point in which pain and illness becomes chronic, that's usually defined as greater than 3 to 6 months after initial diagnosis or the onset of symptoms. So when pain is not getting better, when the illness is not responding to medical interventions, what starts to begin to happen is that there's a sense of, why isn't this getting any better? And psychologically, that becomes very frightening. And what I found in working with a lot of my patients and also trying to work with physicians is that a lot of people are always looking for depression as a response to having illness or pain. When you're not getting better, a lot of people are extremely frightened because they don't know how to control it. So as a result, anxiety leads to avoidant behaviors. Let me show you what this looks like. When you're anxious, you notice everything because it's hyper-focused. The rest of the world begins to sort of fade away from the anxiety that begins to develop about your body and what isn't working. So we have increased notice of pain sensations. When they go to physicians, when they go to healthcare providers, a lot of times what's going on is we have an increase in pain behaviors as they go to the caretaker. And they complain at an even higher degree, perhaps, than when they're at home. They identify themselves as more disabled, that they're less capable of doing things. They also report that they're more depressed. And pain behaviors come into this as well. The grimacing, the sighing, those are the things that they notice even within themselves. When you're fearful, when you're anxious, when you don't know what to do, you oftentimes keep looking for somebody or something to make it better. So there are higher levels of help seeking. They say that they don't know how to cope with the pain, obviously. They don't know what to do. Things that they do attempt to do are done much more slowly because they're convinced that the pain is something they have to avoid at many costs. They have increasing disability levels, and activities of daily living, simple things such as housework, become more and more avoided. Social activities begin to decrease, all because of the anxiety and the fear that's driving these avoidant behaviors. Similar overlaps to what we just talked about with catastrophizing. Here's a really interesting thing I discovered when I was putting this together, something that I actually learned in this process, is that the caregivers themselves obviously have their own belief systems, but those belief systems may impact how they interact with the patient or the loved one with whom they are taking care. And so what can begin to happen is their beliefs can impact the individual with the illness or the pain. And then it has a domino effect because then the patient takes on those beliefs. And I'll talk about dependency issues a little bit later. Now, for the clinicians and the academicians that are in the group, this is an important thing to notice as well, something that there isn't a lot of research, but we're beginning to notice that 66% of clinicians oftentimes have their own types of behaviors and beliefs associated with treating patients. So a number of orthopedists that I will work with will tell a patient, if it hurts, don't do it. Okay? It's actually not really good evidence, or it's not really good advice, because oftentimes if the pain is not going to lead to one's death, if the pain is not going to make things really worse, it's important to try to teach patients to continue to be active despite the pain. But physicians oftentimes will say, don't do it if it hurts. So what happens? They're increasing that concept of disability and the fact that I don't need you to do anything, just be in pain. They're much more likely to recommend sick leave as a good way to manage the symptoms. And what I know, I work with a lot of workers' compensation claims with chronic pain and industrial injuries. One of the things we note is that even when you have such things as limited duty or restricted duty, if you get an individual back to work, even if they haven't completely recovered, they tend to do much better because the activity of work is an important distraction. It addresses such things as self-esteem, productivity, and sense of self. So if clinicians have thoughts and beliefs about pain and avoidance, well, unfortunately, they may unintentionally teach their patients about that. And that's where educating healthcare providers is a critical and very under-recognized issue in this whole process of dealing with chronic pain. The third component, helplessness. Once again, please notice the overlap that's going to come up with this between catastrophizing and pain-related fear. There were some important studies done probably over 50 years ago. I think the gentleman's name was Martin Seligman, and he brought to light the concept of learned helplessness. And basically what begins to happen is when we're faced with a situation that we can't change, we start to believe that we're incompetent, incapable, and the events not only may be uncontrollable, but anything we attempt to do is just useless. And so we develop a mindset, and the mindset is, I'm helpless to do anything. Now, there's an interesting distinction I make when I'm interviewing and evaluating patients between helplessness and hopelessness. So when people feel helpless, there's a concept that they are no longer empowered. It's a self-concept. There's nothing I can do to make this better. And when people are hopeless, even in the outside world, they don't feel like anything is ever going to get better. So oftentimes I distinguish between a sense of self-empowerment and whether or not anybody else can help. So here we go again. Look at the continuity of these three concepts. People who struggle with helplessness as a result of illness and chronic pain, they report higher levels of pain. They have higher levels of depression because they've given up trying. They have higher levels of disability. Why bother? It won't make any difference. And when they feel helpless, their response to medical treatment is often much poorer. And this is where behavioral medicine, pain psychology, which I do, is such an important component of treating people with medical problems, because we need to understand where they are psychologically and their approach to getting better and their attitudes about the healthcare professions and other people that will help them. And many times if I've got somebody who is feeling helpless, I'll tell the surgeon, I'll tell the physician, we really need some psych work here, because no matter what you do medically, they're not likely to get better because we have a huge psychological wet blanket over all of this. Early death, unfortunately, mortality, tends to be a component of people with this type of psychological mindset. So let's look at some other risk factors that are associated with poor coping in the face of chronic pain and illness. Some individuals have black or white thinking. So the idea is, if I'm not completely cured, I'm not going back to work. The concept of having any residual pain or living with pain is untenable to them. They develop a passive attitude to rehabilitation. This is a medical model which is oftentimes very difficult for psychologists to deal with, because a lot of physicians and a lot of people in the medical world are providing treatment to make one better, but they don't engage the patient in terms of what is their responsibility for getting better. So when they come to me, they'll say, Dr. Lacerte, what are you going to do to help me? And I'm going to say to them, I'm not going to do anything. I'm going to teach you the skills necessary for you to make yourself better. And that type of dynamic is oftentimes very difficult, because in the medical profession, it's always, what is the physician going to do to make me better? The thought process or the belief system that pain is harmful and therefore don't do it if it hurts oftentimes gets in the way of the type of work that I need to do with these individuals, and there's a lot of re-education that we have to do. The behaviors that can increase perceptions of pain and oftentimes result from chronic pain include poor sleep, avoiding normal activity levels. We talked about activities of daily living in the previous group under anxiety and avoidant behavior. There's a disproportionate amount of downtime. Why? If I don't do anything, I'll hurt less. Therefore, I'm not going to do anything because I don't want to hurt. Smoking can be a result of, or people who smoke beforehand. What we have here are addictive components. And this makes it very difficult because they're using outside crutches, as it were, to manage. High alcohol intake is a huge problem in terms of self-medicating. I do a lot of pre-surgical evaluations for spine surgery. And oftentimes it's amazing what they'll tell the psychologist that they won't tell their surgeon. So when I have a patient say to me, you know, I used to have some trouble sleeping with this pain, but I take 3 shots of Jack every night, and that really helps. Guess what? I have to be the bad guy, because I'm going to cancel surgery at that point until we get this alcohol issue under control. And then, of course, finally, the report of extreme pain levels goes along with a series of behaviors that's focusing in on the pain, which is something we talked about under catastrophizing. So that's the good news. Not really. Let's talk about the things that need to change in order for people to be in more control of their pain and their illness. There's a concept of self-efficacy. This is really about one's confidence in one's ability to deal with a distressful or difficult situation in order to accomplish a desired outcome. How am I going to approach this? What do I believe about myself in this process? Now, Pay attention to this slide. It's important because what I'm doing is starting backwards. I'm talking about people with low self-efficacy. This ties in with concepts of helplessness and being passive. So they avoid challenging tasks. We're back to this idea, if it hurts, I'm not going to do it at all. Okay? They identify or believe or convince themselves that they are incapable of accomplishing these things. So that once again, we've got a mindset. And here's the old metaphor of the glass is half full or the glass is half empty. So if you have low self-efficacy, if you feel helpless, what you're going to do is see the glass as half empty. I can't do this. I've never been particularly good at this. There's just no way I can overcome this. I just can't make it happen. That leads to, of course, a loss of confidence and higher levels of pain because they don't feel like they have any control over the situation. And then finally, of course, we have the anxiety and the depression, because when you don't have a sense that you are capable, that you have any power, you feel as though emotionally you're distraught. So now we go to what are the concepts involved in increased self-efficacy. So they view challenging problems as a task to be mastered, and that includes pain and illness, okay? They develop deeper interests, so they become focused on their capacity to participate in things, even if they perhaps are in pain. This is not going to stop me is a mindset. This may be very difficult, but I'm not going to quit. That's very different than, I can't do this. This is way too much. I'm overwhelmed. That commitment to interests and activities despite the pain is a psychological mindset, part of self-efficacy. And as a result, these people tend to be much more psychologically and cognitively flexible. They bounce back more quickly. So pain is never static. It's always fluctuating. It's always changing. And so when you hear people who say, my pain never changes, that's not really true. And what I have to do as a pain psychologist is educate them about those fluctuations and how they think about them when they occur. So we have lower levels of pain when you view this as a challenge, something to overcome. And as a result, you have more emotional stability, you have greater levels of psychological strength. Now, I'm going to bring the caregivers back in for a moment. Here's an interesting concept we've been researching. What happens when the caregiver and the patient, the loved one, do not have good communication levels? There's a lot of assumptions going on. So if a caregiver underestimates an individual in pain or illness, if they underestimate their ability to manage the situation, what happens is they tend to swoop in, they tend to want to do everything because that's where they get their sense of self-esteem, and then we create a dependent relationship, and the patient learns inadvertently more and more that they are less and less capable. This leads to what? Higher caregiver strain. I'm going to talk to you about that in a minute. And the relationship is not on equal footing because one person is in control. Overestimating, this is a fine line, and this is where education comes in, because some caregivers are not attuned to the individual, and they abandon them, or they neglect them, and they assume they can do things that they can't. And when you fail to provide the necessary support, it creates all sorts of problems. So, here are some concepts, and I will talk about how you get to these, but I want you to look at some of the ideas involved in how one improves one's self-efficacy. Modeling. Albert Bandura is famous for observational learning. Many times we can learn to do things not because we're being told or we're reading about it, but by modeling. So if a caregiver is taught appropriately how to engage a person in pain in certain behaviors they're attempting to avoid, by modeling that behavior, by demonstrating it, what that leads to is what we call mastery experiences, which is the second bullet point on this slide. Once you begin to perform steps to create a desired outcome, there's a sense that I've been able to accomplish this. What does that do? It increases a sense of self-efficacy. So modeling is a very important concept. It leads to mastery of an experience because with repetition, one gets better at it, one feels better at it, and all of a sudden the dynamics start to change. Social reinforcement, it is so interesting when I evaluate people, how often I will hear about home environments in which my parents expected me to get A's, so nothing was ever said. But if I ever got a B, all hell broke loose. And so what we tend to do, especially in this culture, unfortunately, is we tend to be more critical, and we have a hard time being reinforcing. Verbal praise doesn't cost anything, but it's a huge component in giving people a sense of accomplishment and leading to increased self-esteem and self-efficacy. So you praise people, you reinforce them in their capacity to work through their pain, to manage the illness, and what starts to happen is they feel more empowered. Finally, there is the psychological response, and as a cognitive behavioral clinician, what I'm doing is teaching people, how do I think about my responses? How do I develop the flexibility to snap back when I have an increase in my pain or an increase in my physical symptoms? Some other pain coping strategies. This is somewhat of an ideal. It's very difficult oftentimes to get people to keep diaries about their pain because what can happen sometimes is it focuses on what's going wrong or focusing on the illness symptoms. But this teaches people that if they can become more aware, then they can have more control. So, learning to figure out what are the things that I'm doing that reduce my pain. Learning relaxation skills, a huge component of behavioral psychology and behavioral medicine. Distraction techniques, we all do this. There can be some that are not particularly good, but it can be something as simple as reading, watching television, engaging in conversation. But enough times people who feel helpless have given up on any sort of distraction. Redefining the pain. This is a cognitive concept about learning how to think about the pain differently so that it does not feel like a catastrophe. Venting emotions. One of the things that caregivers need to learn to do is to become good listeners. Oftentimes we are quick to provide ideas, ways to manage things, and what the patient really wants is just to be heard. If I'm in a lot of pain and I tell you this, sometimes all I want you to know is how bad I'm hurting. I don't want you to fix it. So having that outlet and becoming a good listener is a huge component. Seeking emotional support is part of that. That can be done either professionally or it can be done through the caregiver. And spiritual comfort for some people is also extremely important. This is the only slide I believe I have in here that's in red. Nothing that I've talked about so far is going to make a difference without this concept. Teaching people to cope better, to think better, to behave better about their pain, and teaching the caregivers, but ultimately the patient. None of these things work unless the individual takes responsibility for self-management. As I told you at the beginning of this talk, I don't make people better, I teach them the skills to make themselves better, and that's where self-management comes in. Acceptance is an important concept. Now, this is a tough one for many people. This is about being willing to continue to do what you're doing, even if pain-related sensations, thoughts aren't getting better. And I want to make some important distinctions here. Accepting the pain for what it is at the moment is not resignation. It's not about giving up. It's not an end state. And as I mentioned earlier, pain is very fluid. And you have to teach patients this, that their pain is never the same all the time. But acceptance, especially when you're having bad flares in pain, can be a very useful intervention for acute pain management. If you're taking some notes, I didn't put this in the slide and I apologize. Mindfulness has really become the vanguard once again. It's been around for several decades. There's a gentleman by the name of Dr. John, I think it's Jon, the last name is hyphenated, Kabat-Zinn, K-A-B-A-T -Z-I-N-N. He's the real guru of mindfulness. He has an excellent book out, which is probably 40 years old, called Full catastrophe, there's my favorite word again, living. Kabat-Zinn really breaks down the concept of mindfulness. It's like meditation. It's learning to be in the moment. So often when we're anxious and fearful about our illness and we're pain, we're in the future. What's this going to look like? Is it going to kill me? Am I going to make this? I can't stand this. Oh my gosh. Learning to be in the moment and accepting of the pain is a really different way of being present without judging how bad or good it might be. So mindfulness can create very significant short-term improvement in acute pain, and it's part of that acceptance model that it is what it is right now. I need to learn to be neutral about the position I'm in. Some caregiver-assisted concepts. What we've discovered is when you teach the patient coping skills, it's not nearly as good as when the caregiver, the spouse, the partner is involved in this process as well. And what's really interesting is that when you teach caregivers these same type of skills, they rate that their self-efficacy also goes up. They have lower levels of strain and caregiver burnout. So this is a collaborative process that's not thought of very often, but we need to get the caregivers involved. And obviously the bottom part of the slide is somewhat self-evident. If you've got a poor relationship, if you've got poor communication skills, this isn't going to work very well. So where do you go to get this type of help? Everything I've talked about today comes under the rubric of cognitive behavioral therapy. It's the most expedient form of psychological treatment. It's evidence-based, and it's about skills training, both in how you behave and about how you think. So you want to find somebody that's got a cognitive behavioral background, and most specifically, psychologists or mental health care clinicians who have a background in behavioral medicine or health psychology. So that's what you want to look for when you're trying to find psychological help for dealing with illness and chronic pain. Every state has a state psychological association. They usually list the specialties of the various psychologists or mental health care providers in the state, so you can ask for these things specifically. Occupational therapists, which is oftentimes part of a physical therapy group, will have understandings about these concepts as well. And within the insurance component, when we're dealing with Medicare, Medicaid, or even private insurance, there are nurse case managers, and it is their responsibility to know about the clinicians and their areas of specialty. So I encourage you to use these concepts to find the resources necessary to get appropriate pain psychology and behavioral medicine treatment. Okay, now we're going to talk about the invisible patient. We're going to wrap this up. It's really interesting that this really is the invisible group. Healthcare providers, by and large, don't know what's going on with the caregiver because their focus is on treating the patient. They don't ask them how they're doing most of the time. Oftentimes they drop them off at appointments and then they pick them up when the patient's done with the appointment. And so the things that I'm talking about in terms of being in chronic pain and chronic illness cross over in terms of being a caregiver. This is a tremendous burden. Some pretty spooky statistics here. What do we have? 320 million people in this country. 65 million plus people provide informal care. That is a huge percentage of the population, and they're averaging 20 hours a week in terms of caregiving to people with chronic pain and illness. Look at the costs involved. Estimated costs in terms of loss of work to the caregivers, other things that they could be doing to their lives in terms of being committed to helping someone in illness and pain. $374 billion. It's massive. I lied to you. Here's the second slide with red in it. 63% higher mortality risk of being a caregiver than if you aren't. That's what this does to people's health. It's really scary. Some of the accompanying things that come up: weight loss, poor self-care. Obviously, you have poor self-care. What happens to your health? It goes down the drain as well. Sleep deprivation, that's all part of it. Look at the asterisks at the bottom of this slide. It's also indicative of some of the demographics that are going on. Female sex, gender issue here. They're twice as likely to they have a higher rate of caregiver burden than men. And unfortunately, the dominance of caregivers are women. Not surprising. See the overlap that's coming up here? Look at all the depression, twice as high as non-caregivers. Anger. And oftentimes, where do you put that anger? You can't put it out on the patient or your loved one because it just makes things worse, so you bottle it up. You don't use coping strategies. You place your own needs behind that of your loved ones. You deny the seriousness of your own problems. You just shut it down and keep going, and you become socially isolated, decrease social activity. What do we do about this? These are the last two slides. We'll wrap it up. It would be great if we had some sort of national educational program that says physicians need to get on board to start interviewing the caregivers to see if they're experiencing any problems. Wouldn't it be interesting if we were able to basically create consecutive appointments where you see the patient and then you see the caregiver? And there's a burden there within the healthcare system. Insurance isn't going to cover a lot of this, but it could be a critical difference in terms of changing the health of the caregiver population. Respite care can be a very important intervention, giving them some breaks to have somebody come in for short periods of time so that they can take care of themselves. And you need to provide education about caregiver burdens and burnout, and I'll provide that resource on the last page. It's really interesting. When you minimize the seriousness of your own issues, you have a very hard time asking for help, asking for relief. There are caregiver support groups. You'll see this on the list. The technology makes it even better now. You can Skype, you can use FaceTime, you can connect with people all over the planet to try to get some support. Meal delivery service. I know in Colorado, I don't know if this is nationwide, but we have Meals on Wheels. Just one thing about not having to prepare those meals can give a caregiver a break. Home health, visiting nurses is somewhat of an obvious thing. I suspect sometimes it's underutilized, and once again we get into financial issues, but it's a critical break for the caregiver. And even having somebody come in and clean the house once a month so that you aren't doing it. These are simple things. None of this is rocket science, but oftentimes common sense is not very common. Here's the resource page. I'm going to try to figure out a way to put this online so you can get this, because it's a lot of information, but all of these groups provide information for caregiver resources, and they're all critical, from the Alzheimer's Association. Even though we're not talking about Alzheimer's here, they have a really good stress checklist questionnaire where one can self-evaluate for the types of burdens of which you may not be aware that may be affecting your health, both physically and psychologically. And then the rest of them all the way down, including the National Alliance for Caregiving, a very specific organization. That's it. Thank you for being attentive. I appreciate it.